שלום וערב טוב לכולם. למי שלא מכיר, שמי דוקטור נגב בר, אני רופא משפחה ואני יושב ראש החברה לרפואת שריר ושלד. אני רוצה לברך את כל האורחים שלנו פה במכון הכאב ברמב"ם שבאו לקורס לדיקור יבש מתקדם פלא גוף עליון ונמצאים פה ורואים את ההרצאה הזאת בלייב. ואני רוצה לברך את מעל 140 החברים שנרשמו לוובינר הזה מכל קצוות הארץ וגם מחול. אני שמח לפתוח את סדרת הוובינרים, האקדמיה המקוונת לרפואת שריר ושלד. ב-2017 יש לנו את הוובינר הזה. בשנת 2018 יהיו לנו 3 וובינרים. הוובינר הראשון של 2018, מיד נספר לכם עליו. הוובינרים הם חינם לחברי החברה לרפואת שריר ושלד. לפני שאני מעביר את זכות הדיבור לדוקטור סיימון וולפסון, מנהל מכון הכאב ברמב"ם, אני רוצה להודות לחברי הוועד של החברה לרפואת שריר ושלד שתמך במהלך הזה של פתיחת האקדמיה המקוונת לרפואת שריר ושלד. אני רוצה להודות ליעל שעומדת איתכם בקשר בטלפונים ובארגון כל הלוגיסטיקה של החברה, ואני רוצה להודות לצוות ה-Get Webinar, וכמובן I want to welcome and thank you very much Professor Gerwin for giving us the first webinar. Dr. Simon, will you represent Professor Gerwin?
Toda Negev, and I'll move into English. First of all, I really want to greet Bob Gerwin, a very dear friend of ours. We've been working together for a few years, and he so graciously agreed to come and participate in this course, and not only to participate in the course, but also to give the first webinar. And we're soon going to hear about myogenic thoracic pain syndrome. I'd like to mention a couple of important dates coming up. The first one is our annual conference on the 3rd of January. It's taking place in Tel Aviv, in the Kfar Maccabiyah. It's actually not so much Tel Aviv, Kfar Maccabiyah. Really, really good program. Go into our site and have a look and see. And we're looking forward to seeing you all there. Second date I'd like to mention is once again together with Dr. Gerwin, we're going to put on the first international course for dry needling. It's a basic course. The course will be in English. It'll be in Tel Aviv. We've got a lot of Israelis who are very interested. We've got also a lot of people from overseas who are interested in coming to this course, and we're hoping it's going to be very successful. It's intensive 2 days. The basic course, the people who are sitting here in front of me have all done the course. I'm sure a lot of you at home have. And those who haven't, tell your friends. Or those who have, tell your friends. Tell them to come along. It's a fantastic opportunity to learn about myofascial pain and dry needling, and especially to learn from Dr. Gerwin. The next webinar will take place in our next advanced course on the 22nd of March, Thursday evening. And my dear friend John Kent and I will be passing the ball back and forth and deciding, or trying to decide, what sciatica is. Is it a somatic referred pain? Is it a radicular pain? And so on. We're going to be looking at the history of sciatica. We're going to be looking at the pathophysiology. And hopefully by the end of the evening, we will have given enough ideas and thoughts in our debate that you will also find it very interesting. So without further ado, let's get on to Professor Bob Gerwin and the webinar on myogenic thoracic outlet. Thank you very much.
Inviting me to present here this evening. I'm going to be talking about thoracic outlet syndrome. I'm going to be putting it in the framework of true neurogenic thoracic outlet syndrome and disputed thoracic outlet syndrome. And that will take us into a concept of myogenic thoracic outlet syndrome, which is a term which I think is unique to my usage and is not found in any of the literature except what I have written. But I will present it to you as an interesting way of looking at what thoracic outlet syndrome is and is not. So thoracic outlet syndrome can be classified in a way that Asa Wilburn classified it maybe 2 decades ago. And Asa Wilburn, who is a neurologist at the Cleveland Clinic, classified thoracic outlet syndrome as true neurogenic thoracic outlet syndrome, and then vascular, true vascular, either arterial or venous, traumatic, which can be thought of as a subset of true, either vascular or arterial or neurogenic, because the symptoms come from compression of arteries, veins, or nerve. And then disputed, which we will get into a bit later. And you should know at the beginning that true thoracic outlet syndrome of any of these categories is rare, despite the fact that historically thoracic outlet syndrome diagnosis was made to an amazingly common degree. And at one time, if you can believe this or not, surgery for thoracic outlet syndrome, scaleotomy, was the most common surgical procedure in the United States. Well over 250,000 cases a year, just an amazing number of cases. And that really raised the question of whether or not these procedures were indicated or not. The sites for thoracic outlet syndrome, neurogenic or vascular, to occur are shown in the slide. And you have the possibility of compression of the nervous tissue, that is the brachial plexus, in the interscaling compartment. You have the possibility of the compression between the clavicle and the first rib. That's the costoclavicular space. And finally, you have the possibility of compression of the neurovascular bundle under the coracoid process beneath the pectoralis minor muscle. That's the hyperabduction syndrome. Thoracic outlet syndrome as a term denotes a pain syndrome and either a disorder of vascular structures or nerve impairment, but it does not denote where this occurs. It doesn't denote a site. It denotes a problem in the shoulder affecting the brachial plexus or the neurovascular bundle. So it's not specific to what structure is involved. True neurogenic thoracic outlet syndrome, that's thoracic outlet syndrome that involves the brachial plexus and its derivative structures, is a disorder of axon loss, which is important ultimately in the diagnosis. And it is not a disorder of demyelination as, for example, diabetes mellitus is. Now, neurogenic thoracic outlet syndrome has classically been related to the sites of brachial plexus and nerve or nerve bundle compression. And the sites, as I mentioned, would be in the interscaling compartment between the anterior and the medial scaling muscle, so the interscaling space. Between the first rib and the clavicle, that's what's been called the thoracic outlet, or if you, depending which direction you're going in, I suppose you could call it the thoracic inlet space. Underneath the pectoralis minor muscle, which we just mentioned, is the hyperabduction syndrome. And then if you have a dislocation of the humerus, it's possible to compress the structures that derive from the brachial plexus, the nerve bundle, by a dislocated humeral head. And in this cartoon, we have a drawing, a diagram of the neck and the shoulder, basically the scaling muscles, the nerve roots, the brachial plexus, the neurovascular bundle. We've cut the clavicle so you can see where the neurovascular bundle comes under the clavicle. And not shown well, but shown as a truncated structure, is the vein which does not pass through the interscalene compartment, but is ventral to the anterior scalene muscle. And that's an important point to note when you're thinking of involvement of the neurovascular bundle in the interscalene compartment. Now the question comes up is, can you actually compress the neurovascular bundle, the subclavian artery and the brachial plexus or the nerve roots in the interscalene compartment? And a neurologist in St. Paul, Minnesota, many years ago, did a series of studies with CAT scan investigation of the interscalene compartment and showed that in patients who had symptoms of thoracic outlet syndrome, who had involvement of the medial and or the anterior scalene muscle, that when these muscles were hypertrophied, and that is something that happens when they are shortened because of trigger points, the length of the muscle is shortened, and because muscle is 75% water, the volume has to be maintained. So when you shorten a vessel that contains water, you have to increase its diameter. So the cross-sectional diameter of the scalene muscles increases. That means that the interscalene compartment gets compressed. And he showed in a series of CT scans that the interscalene compartment disappears in these patients, making the point rather dramatically that compression of the structures within the interscalene compartment can certainly occur when the scalene muscles cross-sectional diameter is increased. So once again, another cartoon that shows the structures of relevance to us. Once again, the anterior medial scalene muscles, the brachial plexus, and the neurovascular bundle, now including the subclavian vein, which is shown ventral to the anterior scalene muscle. But as it goes through the thoracic outlet, or between the clavicle and the first rib, all three structures, that the vein, artery, and nerve bundle, are together, where they can be compressed, and then they all pass under the coracoid process and under the pectoralis minor muscle, medial to the head of the humerus, and at any of these sites, that is in the interscalene compartment, at the costoclavicular space, and under the pectoralis minor, they are vulnerable to being compressed. And we're going to talk about whether that happens in the normal situation or not for true thoracic outlet syndrome. This cartoon or diagram shows that in true thoracic outlet syndrome, as opposed to disputed or myogenic thoracic outlet syndrome, neurogenic or involvement of the nerve tissue is the most common presentation for thoracic outlet syndrome, occurring in over 82% in this study published in 2017. And disputed or not true thoracic outlet syndrome is the next most common, more common than the venous and more common than the arterial thoracic outlet syndrome. So in this study, it comprises a small but significant number of cases of thoracic outlet syndrome, but I think this diagram is misleading because this was a referral center and the patients sent to them were primarily those with true neurogenic thoracic outlet syndrome. And on the right side, for traumatic thoracic outlet syndrome, there are a number of cases, recreational injuries, accidents, occupational, and so on. The point that Asa Wilburn made is that not true thoracic outlet syndrome or not thoracic outlet syndrome was a very common problem and represented a gross misdiagnosis of the condition and resulted in a grave overuse of invasive therapy, surgery. Symptoms of thoracic outlet syndrome, and again, neurogenic true thoracic outlet syndrome, include neck pain, shoulder pain, upper back pain in 99% of the cases. So the pain in the shoulder, upper limb, and hand is the major presenting complaint in true neurogenic thoracic outlet syndrome. Now, the next point is very important for true neurogenic thoracic outlet syndrome as opposed to what Wilburn called disputed thoracic outlet syndrome and what I have called myogenic thoracic outlet syndrome. And that is that in true neurogenic thoracic outlet syndrome, there must be some impairment of nerve function. And that impairment of nerve function can be sensory or motor. If it is sensory, it will be numbness or paresthesias or dysesthesias. Paresthesias, tingling. Dysesthesias will be a painful tingling or a painful sensation. Motor symptoms will be either weakness in the hand or less commonly in the forearm, or take the form of atrophy of muscle, of the intrinsic muscles of the hand, or sometimes the forearm muscles. The characteristics of the symptoms are that, and by the way, I just want to point out that that in true thoracic outlet syndrome, neurologic symptoms are so common that not to have them should throw doubt on the diagnosis. So in this study, they were 94% of the patients who presented. Symptoms are worsened with pain elevation, with arm elevation, and that would go along with the involvement of the hyperabduction syndrome or the involvement of the pectoralis minor syndrome, which, as we will see later, is a comorbidity with true neurogenic thoracic outlet syndrome in almost 3/4 of the cases that present. Prolonged use of the arm and hand represents a form of claudication. And claudication can be either vascular, arterial, or it could be neurogenic claudication. So that as you put the muscles into use in the forearm and the hand, pain will result. And that again was at a almost 90% incidence in this, this study. And pain radiating from the shoulder area, the supraclavicular area, down into the arm is likewise very common. Local tenderness to palpation in the scalene triangle over the brachial plexus or in the supraclavicular fossa is quite common. And reproduction of the symptoms in the upper limb or hand by palpating in the proximal regions, that is palpating in the supraclavicular fossa over the brachial plexus or in the over the interscalene compartment, is likewise common. And then we get to provocative testing, and this is interesting because in this study, the provocative upper arm tension test, which is an abduction of the arm and then a dorsiflexion of the wrist and then turning the head and bending the neck, was positive in producing symptoms in a large percentage, over 80% of the patients. And then the East test, what's often called the Roos maneuver, with elevation of the arm, was positive in these patients. But I will show you later it is a very insensitive, it's a sensitive test, but very non-specific test. And therefore, its use has been degraded. It's no longer recommended to be used as a very useful test because of its lack of specificity. Now, the clinical diagnosis of thoracic outlet syndrome is made on the basis of the pain, the neurologic symptoms, and then signs of either arterial or venous involvement. The problem with the first issue, which I tended to indicate in the previous slide, is that the symptoms of pain are nonspecific. Because there are a lot of problems that can produce pain in the shoulder, and then in the arm and in the hand. Adding in signs of neurologic impairment, including sympathetic nervous system impairment, increases the specificity for the diagnosis of thoracic outlet syndrome, but is still not terribly specific. It may be sensitive, but not terribly specific. And that is because other conditions, particularly for neurogenic thoracic outlet syndrome, can mimic this. Radiculopathy being a very common problem. The difference being that radiculopathy from cervical nerve root compression tends to involve the distribution of one cervical nerve root, whereas thoracic outlet syndrome involves the distribution of more than one nerve root. And we will see how that affects the electrodiagnostic testing that is used now for the diagnosis or confirmation of the suspected diagnosis of thoracic outlet syndrome. Arterial compression for arterial thoracic outlet syndrome is made with the symptoms of claudication, and then the findings of pallor, coldness, signs of compromised blood flow into the hand and the arm. And venous thoracic outlet syndrome is diagnosed on the basis both of pain and then the associated finding of engorged collateral venous circulation and edema and cyanosis in the arm and in the hand. As far as the neurologic abnormalities are concerned in thoracic outlet syndrome, we mentioned already sensory loss is primarily in the medial aspect of the arm when the arm is put into the anatomic position. So it's going to involve, primarily when you get down to the hand, it's going to involve the lateral, the medial fingers. That's going to be the little finger, the ring finger, and perhaps the long finger. You don't expect the thumb to get involved. The paresthesias are going to be, again, in the medial aspect of the arm more than elsewhere. And paresthesias, the complaint of tingling and numbness, is going to be a prominent part of the patient's complaint. In terms of looking at the patient on physical examination, atrophy of intrinsic hand muscles are a common finding in true neurogenic thoracic outlet syndrome. The question of tendon reflexes is interesting because tendon reflexes tend to be preserved in situations where there is axon loss, but there is still some axon preservation, so all you need is the connection from the tendon that you're getting the reflex from in the central nervous system, and as long as there is some preservation of nerve axons, the reflex will be preserved. And the reflexes, particularly C5 and C6-7 reflexes, will be preserved, particularly because the main involvement of true neurogenic thoracic outlet syndrome is focused on C8 and T1 nerve roots, so they don't affect the biceps and triceps reflexes or the brachioradialis or finger reflexes to enough of a degree to alter tendon reflexes. For the arterial thoracic outlet syndrome, there is often an asymmetry in blood pressure between the two arms, so complaints of upper extremity pain and shoulder pain should always lead the clinician to taking a blood pressure in both arms and comparing them. the problem of the sensitivity and specificity of taking blood pressure in the arm with the arm hanging by the side and the arm elevated to compress structures. That doesn't work so well. It's not a very sensitive test, and the reason for that is for many people the blood pressure falls and the pulse decreases when the arm is put into abduction anyway. So it's not a very sensitive or specific test. And finally, in patients who have venous thoracic outlet syndrome, and actually patients with arterial thoracic outlet syndrome, where there is compression in the costoclavicular space, and you develop, particularly in the arterial situation, you develop a post-compression enlargement, and in that enlargement, thrombus can occur, and emboli can occur from the thrombus, and you can then see that as hemorrhages in the fingertips themselves.
Gerwin from Manoff asked you, there are major lymphatic channels passing through the thoracic inlet to their exit into the subclavian vein, and they are vulnerable to compression and compromise. Is there any reason they have not been mentioned or referred to in regards to the clinical significance in thoracic outlet so far in your discussion?
It is an interesting question as to whether or not the lymphatic system is involved. I can only tell you from a theoretical point of view, you would say that this is likely. The question is whether or not the lymphatic channels are actually passing under the pectoralis major muscle. Do they go through the costoclavicular space? I actually don't have an answer to that question. And I can only tell you that that has not been addressed in the literature that I've looked at. And I've looked at a fairly extensive review of the literature. So it's an interesting question, and I'd really have to look at the anatomy of lymphatic flow to be able to answer that better. There are a number of provocative tests that are used. I will show you a picture of a Syriax test. I don't want to dwell too much on these because I don't think that these clinical tests are greatly of great use. I do want to mention one test, two tests, which really have been discredited and which are absolutely not recommended for use. And those are the Roos maneuver, which is the elevated arm stress test. You may all know it's the arms elevated, and then you're supposed to open and close the hand repeatedly for 3 minutes. We used to kid that our professor would have one of us with our patient performing this East test for 2 minutes, and then the professor would come in and perform it with the patient for the last 1 minute, and then ask the patient why the patient thought he was getting tired when the professor wasn't getting tired at all. But this is actually a rather fatiguing test. And Asa Wilborn, who considered this test to be rather non-specific and not of great use, looked at this test, again, almost 2 decades ago or more. He looked at this in 1,200 patients. And the conclusion of his study was that the test is very good for identifying carpal tunnel syndrome, but has no specificity whatsoever for thoracic outlet syndrome. And the Adson's test, which many of you are familiar with, likewise has been discredited as being useful in the clinical diagnosis of thoracic outlet syndrome. The Syriax release test is an issue of raising the shoulders and basically trying to take the pressure off of both the scalene muscles, but particularly to open up the costoclavicular space. Again, I don't think that these clinical tests are of great value. I think it's much more important to identify neurologic impairment by a good neurologic examination rather than doing these provocative tests. Clinical tests that will support the diagnosis then should give way to the laboratory testing signs. And the testing that is done in laboratory testing involves both imaging studies and electrodiagnostic studies. And that's really the two major types of studies. CAT scans can be used, and actually plain x-rays can be used to look for a cervical rib. And in the true neurogenic thoracic outlet syndrome, an elongated C7 cervical rib or a ligament from the tip of that rib to the first, the tip of that lateral process, transverse process at C7 to the first rib, is considered to be the major cause of true neurogenic thoracic outlet syndrome. Which is interesting because most of our patients who complain of pain in the arm and who we give the diagnosis of thoracic outlet syndrome to do not have a cervical rib. But for true neurogenic thoracic outlet syndrome with nerve impairment, this is almost always the case. You almost always find them. So you see them on plain x-ray. The question comes up, can you see a ligamentous band on plain x-ray? The CT scan has been used to improve the diagnosis of ligamentous band. And the MRI scan has been shown to identify edema in the brachial plexus as an indication that there's a brachial plexopathy or brachial plexitis, which would strengthen the diagnosis or the concept of the diagnosis, confirm the diagnosis, if you will, of a thoracic outlet syndrome. Ultrasound can be used for the same purpose of identifying a ligamentous band, which will entrap the C8 or T1 nerve roots, which are elevated as they go over this, this band. The cartoon up here is intended to give some idea of some of the variations of cervical ribs and ligamentous bands that arise from them. The arterial thoracic outlet syndrome is most often caused by some kind of bony abnormality such as a cervical rib or a fracture. The ones that I have seen invariably have occurred in patients who've had clavicular fractures and then a malunion with a large callus that compresses the vascular bundle. Like neurogenic thoracic outlet syndrome, arterial thoracic outlet syndrome is uncommon. It is rather rare. Unlike neurogenic thoracic outlet syndrome, which has a slight female predominance, the arterial thoracic outlet syndrome and venous thoracic outlet syndromes do not have a sex or gender preference. Venous thoracic outlet syndrome occurring by itself, again, is rare. All of these three syndromes, the true neurogenic, the true arterial, the true venous, are unilateral syndromes predominantly. They are rarely bilateral, which is a major difference between them and myogenic thoracic outlet syndrome. In the venous thoracic outlet syndrome, again, edema, dilated veins, and collateral venous channels are prominent. I just emphasize again that for venous thoracic outlet syndrome, the problem is not in the interscalene compartment because the subclavian vein does not go through the interscalene compartment. The use of electrodiagnostic techniques to confirm the diagnosis of thoracic outlet syndrome has been a major concern because standard nerve conduction studies are by and large normal and not useful. When there is atrophy, then the electromyogram can show that there are denervation potentials, but it doesn't show you where the problem arises. It doesn't give you the location of the compression or the injury to the brachial plexus or to the peripheral nerves. That's a problem. The first indication, the first publications 15, 20 years ago made the point that the electrodiagnostic abnormality in thoracic outlet syndrome was a decreased amplitude, decreased voltage, if you will, in lay language, but decreased amplitude of the action potentials, the compound motor action potential or the sensory nerve action potential in the distribution of more than one nerve. This has been greatly refined now, and I will come back to this, but we now use the antebrachial nerve, medial antebrachial nerve action potentials compared to the action potentials of motor and sensory in the hand to make the diagnosis, showing abnormalities in amplitude of these nerve potentials in the distribution to C8 and T1, and I'll come back to that a little bit later. So it's the medial antebrachial cutaneous nerve, sensory nerve action potential that is low in amplitude, or you can't get it. And the median motor or compound motor action potential to the thenar eminence shows, again, low amplitude. But in the ulnar sensory nerve action potential to the little finger, comparing that to the second finger gives you a difference because it's low in the little finger and it's normal in the second finger, and this allows you to localize involvement to C8T1 and as opposed to other nerve roots. When a diagnosis is made of true neurogenic thoracic outlet syndrome, physical therapy, myofascial therapy may be used. For arterial and venous thoracic outlet syndrome, generally speaking, one goes directly to surgery. And the surgery, when physical therapy or conservative therapy fails, which is relatively a common problem in true neurogenic thoracic outlet syndrome, then resection of the first rib to open up the costoclavicular space is often performed, and resection of the anterior scaling muscle or scaenotomy is performed. Now, most thoracic or vascular surgeons that I know who perform these procedures want to be as certain as possible that an invasive procedure such as a scaenotomy or removal of the first rib, and remember that the anterior scaling muscle attaches to the first rib, so if you're going to remove the first rib, you're going to be performing a scaenotomy. So is that going to work? So that has given rise to another test that, at least in my experience, has been commonly used, and I haven't really seen this written in the literature, but in the last 5 years, I have found it exceedingly common, practiced by the surgeons that I refer my patients to, and I have referred my patients to the people in the United States who are considered the top level of people who work in this area. And that additional test is to do first a local anesthetic block to the scalene muscles to see if there is a quick reversal of pain. But in almost every case, they will resort to injection of botulinum toxin into the scalene muscles, either ultrasound guided, CT scan guided, or blindly. And since these muscles are actually rather easy to inject, if you know the anatomy, you can do this without imaging of any sort, and then see over the ensuing weeks whether there is an improvement in the patient's symptoms. And the concept there is that if the scalene muscles are shortened, or they're tight, they're fibrotic, and you can relax them, the interscalene space will increase, the first rib will drop, increasing the costoclavicular space. It has nothing to do with the pectoralis major muscle, but it is relevant to the issue of whether you should do a scalenotomy or a first rib resection. And if these tests are negative, my experience is that the surgeon, the thoracic surgeon, is often unwilling to proceed with surgery. So it's an interesting approach, which I have done myself and my patients. And when botulinum toxin injection into the scalene muscles has consistently relieved symptoms, I found that surgical treatment, scalenotomy, first rib resection, has been effective in reducing the symptoms. Once again, the sites of compression of neurovascular bundle. I'll remind you again, interscalene compartment, costoclavicular space, and under the first rib for the pectoralis minor syndrome. Now, there is a physical therapy provocative test to see if the first rib is elevated, and it's displayed here. On your left side, there is a restriction in movement because of an elevated cervical rib, and the full motion is on the right. Is that a useful test? Again, I don't know that it's useful to go to these when you have imaging to see whether there is a cervical rib, a ligamentous band, edema in the brachial plexus related structures that flow from it, and now good electrodiagnostic tests for this. The pectoralis minor syndrome or hyperabduction syndrome is another cause of what you could call a true thoracic outlet syndrome, but it's not thoracic outlet because the compression of the neurovascular bundle is not in the thoracic outlet space. It's not the costoclavicular space. Strictly speaking, interscapular space compression is not thoracic outlet either because it doesn't occur between the clavicle and the first rib. But the way we talk about this in our terminology, we would include all three sites as potential causes of compression of elements of the neurovascular bundle. The epidemiology of pectoralis minor syndrome is interesting. It occurs in as many as 75% of patients who have true neurogenic thoracic outlet syndrome, and that is a large number. But I think it also occurs in many patients who do not have neurogenic thoracic outlet syndrome, but I don't have any statistics for that. Isolated pectoralis minor syndrome, in this study at least, occurred in only 1/3 of their cases. That is without involvement of either the nerve bundle or arterial or vascular bundle. There is, unlike true arterial or vascular thoracic outlet syndrome, there is a female predominance, which is similar to true neurogenic thoracic outlet syndrome. And it is mostly a combined syndrome. Both nerve and vessels are involved. And the other thing that is of interest is that you see it in children as well as you see it in adults. And in children, either mostly in children who are physically active in athletics and sports, particularly in those sports where the arm is abducted. In another study, the pectoralis minor syndrome had neurologic symptoms alone without the arteriovascular component in under 4%, which is an astounding figure. So it's mixed neurologic and arterial in 34%, arterial alone in over half the cases, and complicated means that it was associated with other systemic illnesses rather than either trauma or overuse of the muscle. And in this diagram, again, just showing the pectoralis minor muscle, the neurovascular bundle, and showing where the arteries and nerves can actually be compressed. This is the one that this is very clear. As the muscle, as the neurovascular bundle goes underneath the pectoralis minor muscle under the coracoid process. And the figure here shows the hyperabduction motion. And you can see that as you raise the arm and abduct the arm, that the neurovascular bundle is going to be pulled upward. And if that pectoralis minor muscle, or those three heads of the pectoralis minor muscle, are hypertrophied, you can see how a neurovascular bundle put on traction might increase, be increasingly compressed to the point where it can develop symptoms. Once again, just showing the interscalene compartment, scalene muscles, carotid artery, costoclavicular space, and here we don't see the pectoralis minor muscle. Now, I want to move on to what I think is the most common presentation that we see clinically, because remember that true thoracic outlet syndrome is not a common problem. But diagnosis of thoracic outlet syndrome has been exceedingly, disturbingly common. And the question is why? What is it that makes this, that leads clinicians to diagnosing this condition when it doesn't occur, according to Asa Wilburn and others who have looked at the statistics on this? The disputed thoracic outlet syndrome has been said to be a variant of what's been called a scalenus anticus or anterior scalene syndrome, which is simply a way of saying that the neurovascular bundle is compressed in the interscalene compartment. It is much more common in women than it is in men. It is most often bilateral. It has been said to be caused by compression at various sites. Where are those sites? The sites that I've shown you again and again and again, so that when you leave tonight, you can dream about the sites of compression of the neurovascular bundle in the interscalene compartment, the costoclavicular space, and under the pectoralis minor muscle, so that you will never forget this for the next 50 years of your practice life. Oddly enough, in the disputed thoracic outlet syndrome, there are, despite the fact there may be some complaints of paresthesias, there is no objective impairment of the neurologic system. There is no sensory loss that you can identify. There is no atrophy. There can be claudication-like symptoms. In other words, patients use the arm, they get the arm fatigues and gets tired, and pain may increase. But there may be other reasons for that. The problem with the list of symptoms that I showed you earlier, where pain was present in 99% and sensory loss in 80-some-odd%, is that while they may be sensitive, they are not specific. And that is the real problem. And finally, many of these patients with disputed thoracic outlet syndrome are involved in litigation, and that, at least in the United States, I don't know about in Israel, but that is a further curse on our consideration of thoracic outlet syndrome that does not have a cervical rib, does not have a ligamentous band, does not have a callus on the clavicle, does not have objective neurologic impairment or objective abnormality on arterial studies. And I didn't mention in terms of diagnosis of arterial and venous studies, which I should have. Obviously, venography and arteriography are used to make those diagnoses. But talking about the disputed thoracic outlet syndrome leads me to myogenic thoracic outlet syndrome. So what do I mean by myogenic thoracic outlet syndrome? I mean thoracic outlet syndrome which is caused by changes in the muscle. And what changes in the muscle are we likely to be talking about? We're really likely to be talking about myofascial trigger points that occur in the scalene muscles. And there are many reasons for this. Basically, scalene muscle overuse, which can occur because of respiratory problems, because scalene muscles are accessory respiratory muscle. There's an accessory respiratory muscle. Head movement, neck movement, the way we hold ourselves, psychological problems where you get tight, all the reasons that scalene muscles can be involved with trigger points. The trigger points will shorten the scalene muscles, and as I said before, will increase the scalene muscle cross-sectional diameter so that they will be enlarged. That will have certain consequences. The first consequence is that will decrease the size of the interscalene compartment. The second consequence is that trigger points in the anterior scalene muscle will raise the first rib and will decrease the space of the costoclavicular space. So it narrows the thoracic inlet. And it is very common to have comorbid trigger points. In other words, trigger points seldom occur in one muscle, but they commonly occur in multiple muscles. So you have in the scalene muscles, it's not uncommon to have in the pectoralis minor muscle. So you can have involvement both of the scalene muscles and a hyperabduction syndrome caused by involvement of the pectoralis minor muscle. So this causes intermittent compression of the neurovascular bundle. And it's, to my mind, something similar to what might happen with early symptoms of carpal tunnel syndrome, where the symptoms may be intermittent, the patient may have pain, but at that point you don't have any abnormality of electrodiagnostic testing. You don't have any obvious muscle atrophy. So that would be, trigger points would be an actual cause of myogenic thoracic outlet syndrome or disputed thoracic outlet syndrome. And the treatment for that, well, first of all, the diagnosis is going to be based on identification of trigger points. And the treatment will be confirmed by treating the trigger points and seeing the patient gets better. Because the electrodiagnostic studies, imaging studies will not be of any help. They'll be normal in this situation. And again, just shows you the structures we're talking about. And in these courses, you have been exposed to how to treat the scalene muscles and the pectoralis minor. We're going to talk about the pectoralis minor tomorrow. Here's the scalene muscles and the referred pain, which we will come back to in 1 second about from the scalene muscles, and a comment at the bottom about the use of botulinum toxin in diagnosing true neurogenic thoracic outlet syndrome. Can you use it in trigger point therapy? Well, the answer is yes. And that is, if I have a patient who I think has scalene trigger points as a cause of neck pain, shoulder pain, symptoms down the arm, with normal neurologic function. And I treat the trigger points, I needle them all, they get better, they repeatedly improve, but the improvement is transient. I will go ahead and treat these patients with botulinum toxin because it's basically a 3-month trigger point needling procedure that lasts about 3 months. And it then gives me time for the physical therapist to work with these patients and to see if we can't move this patient along with conservative therapy to recovery. And I can also then have the leisure to try to do the corrective actions that are needed to deal with whatever the problem was that started the myofascial pain syndrome in the first place. So we have treatment of the scaling syndrome, if you will, which is intended to open the interscalene compartment and open the costoclavicular compartment. And finally, I'd like to come to what is a look-alike problem, which I think is very common and probably the most common reason for people being diagnosed with thoracic outlet syndrome that is not true thoracic outlet syndrome. And I have no statistics available to tell me which is more important, whether my concept of myofascial pain causing thoracic syndrome-like symptoms or referred pain from myofascial trigger points in the neck and the shoulder, causing a look-alike syndrome that causes referred pain down through the shoulder, into the arm, into the hand. That is by far and away the most common reason that I have these patients referred to me by the thoracic and neurosurgeons. See if these patients really have thoracic outlet syndrome or see if they have something I can, quote, fix. And I put down on this slide many of the muscles of the neck and shoulder that refer pain into the shoulder and down the arm that will look like thoracic outlet syndrome, will cause pain on movement, limited range of motion, do everything thoracic outlet syndrome can do. Maybe also many of these, some of these like the scaling muscles, the pectoralis minor muscle will also cause intermittent compression of the neurovascular bundle, making the life more complicated. But I call these last two syndromes, the scaling and pectoralis minor hyperabduction syndrome caused by trigger points where you actually have neurovascular bundle involvement, and myogenic referred pain or trigger point referred pain that mimics thoracic outlet syndrome pain, but both of these have normal neurologic and vascular findings. I call these syndromes myogenic thoracic outlet syndrome because it looks like thoracic outlet syndrome. It is often confused for thoracic outlet syndrome, and it's my belief, which I cannot prove, that many of the surgical procedures that were not really necessary in the past were performed because the patients had trigger points in the muscles of the neck and the shoulder. So this is the case that I would make for myogenic thoracic outlet syndrome. And again, emphasize to you that true neurogenic thoracic outlet syndrome and vascular is rare. This is very common. So thank you very much. Any questions? Simon?
Go ahead. Any questions?
And can myogenic thoracic outlet syndrome cause a true nerve entrapment because of these objective neurological signs and electro diagnostic signs?
Yes, I think that the issue
treatment will improve neurological thoracic outlet syndrome?
Well, there's the question. Can trigger points in the scaling muscles, for example, cause enough compression of the neurovascular bundle in a sustained manner to produce true neurogenic thoracic outlet syndrome is a question that has not been asked for experimentally, and so I can only give you an opinion which is not backed up by data. I think it is possible. I think that some of the cases that is true. We certainly see patients with true neurogenic thoracic outlet syndrome who have scaling muscle trigger points. Now, if there is a cervical rib or a ligamentous process, I think the question is irrelevant, because then if you have really have signs of nerve impairment on electrodiagnostic testing or clinically with atrophy, for example, you have to do a release. If you don't, I think you have the luxury of doing conservative treatment and seeing what happens.
Okay. Yeah, one more question. Thank you. Okay, one more question coming from the community, from the web. Bob, can you expand on the link with carpal tunnel syndrome? That's from Simeon Neil Asher, who asked that question.
If you rephrase the question, you would say that is there an association of carpal tunnel syndrome and true neurogenic thoracic outlet syndrome? And as I read the literature, it seems to be that there is a greater incidence of carpal tunnel syndrome in patients with true neurogenic thoracic outlet syndrome. They should not be confused one with the other, however.
Okay, one more question.
I would like to ask about the clinical aspect of thoracic outlet syndrome vis-a-vis more common phenomena like whiplash injuries or traffic accident injuries. Is it an overlap with symptoms that I, in my clinic, can differentiate between the two?
The question is whether or not there's an overlap between whiplash-associated disorders and other injuries and thoracic outlet syndrome. I would say that the kind of problem that occurs with whiplash is more likely to be a brachial plexus injury, unless that patient has a structural abnormality like a cervical rib or a ligamentous band in which you may increase the traction against the offending structure by movement of the head. Again, the number of people who have these abnormal structures is rather small. The number of people who have shoulder and neck pain from whiplash-associated disorders, for example, is rather relatively high. And I think we're dealing more with either muscular problems, trauma-induced myofascial pain, or stretching injuries, avulsion, or in the extreme extent, stretching injuries of the brachial plexus. That's not really what I would call thoracic outlet.
Okay, so thank you very much. Thank you to Professor Bob Gerwin for a wonderful seminar for us. And we're looking forward to seeing you in future dates. Get onto the internet, get onto our site, and you'll see all the dates, the relative important dates coming up. ismm.org.il. We've got our annual conference coming up. We've got an international course coming up together with Bob. We've got a webinar coming up. All these will take place in 2018, and have a good evening. Thank you.